Hello, everyone. My name is Adriana Chacon Escuro. I am a senior director at the Community Healthcare Association of New York State, which is better known as Chicanes, and I want to welcome you to the 2026 Health Center Board Learning Series. This is a three-part series, and this session is titled Health Center Board Governance in Action: Authorities, Oversight, and Operational Site Visit Readiness. Thank you for taking the time to view the session. After viewing, you can access the session slides as well as a short feedback survey by clicking the links in the description below. We truly value your feedback, and it helps to inform Chicane's future board learning sessions. Now I'd like to briefly introduce the presenter, Carrie Riley, counsel at Powers Law. Carrie has about 20 years of experience working with federally qualified health centers nationwide. We are so glad to have Carrie present this session on board authorities, oversight, and OSV readiness. And with that, I'll pass it over to you, Carrie.
Thank you so much. So this is our roadmap for the day, and this is part of a three-part series. So we have one webinar that is on kind of general best practices, fiduciary duties, and then one on board composition requirements, and then today, which is a focus on the board's authorities. And as we capture in the other two webinars, this emphasis on the governing board within this health center program is quite unique. Within the compliance manual, there is a whole chapter on board composition. There is a whole chapter on board authorities. And so those authorities is what I want to focus on today. I'm going to kind of kick it off with kind of a big picture of foundation in terms of the role of the board. Then I'm going to talk about the health center program specific requirements. And then I'm going to describe the review process, the operational site visits that are conducted to assess the health center's compliance with the programmatic requirements. I'm going to focus on the role of the board, the interview that will occur with the reviewers, and give you some tips to prepare. So with that, again, I want to kind of kick it off with kind of the unusual and really, in my eyes, very special role of the governing board within this program. I'm guessing that a lot of you serve or have served on other nonprofit boards. This is pretty unique, right? In the statute, in the law, in the regulations, there's this very strong emphasis on the community board in terms of defining this health center project, in terms of overseeing its operations. So this idea of this engaged, involved board is not just best practice. It is mandated under the law for this program. And that really stems from the origins of this program. Maybe you heard the other compliance board webinars we're doing. But it's worth restating that this program evolved from this recognition that there were certain consistent themes that were being seen in these low-income communities in terms of the need for comprehensive primary care. There was also this recognition that the best individuals to make these very important decisions about where are the sites, what are its hours, who's monitoring the budget. That is not the government, that is not management, that is the community. The community is in the best position to make these decisions, and in particular, patients. So hence we see this evolution within the program of this emphasis on governance, on you all in terms of both composition, that's the other webinar, and then today, your authorities. So you can see here, this language is directly from HRSA policy. You provide leadership and guidance. You are responsible for establishing and approving that scope of project, which defines your federally supported or federally designated activities. You'll see here I have pillars. I really view the board as a core pillar of this program. And kind of separate and apart from the HRSA side, it is important to discuss and acknowledge that there are these general fiduciary duties that rest with nonprofit governing boards. And the term fiduciary, interestingly, comes from the word, I could be mispronouncing this, but fiducia. I never took Latin. Anyways, it means trust. So at its core, it means that you are entrusted to act in the best interests of the organization, of the nonprofit. And this is especially important in the health center context because you aren't just overseeing a nonprofit, which in and of itself is very important. You are stewards of a federally funded program. So you're receiving public funds to carry out a specific mission, providing access to care for underserved populations. So your fiduciary duty is to see that that mission is carried out. The other webinar on best practices and fiduciary duties will spend some more time on these three core fiduciary duties. And I will say, New York has quite a bit of guidance in terms of what these fiduciary duties mean. So it's very much impacted by your state's nonprofit law. So, what are those three core fiduciary duties? The duty of care, loyalty, and obedience. So, duty of care means that you are expected to make informed decisions. That doesn't mean you need to be an expert in every area, but it does mean that you are asking questions, you're reviewing materials, you are prepared, you're asking for training when that is identified as a need. Again, we're going to spend some more time on that on the webinar related to best practices and fiduciary duties. The duty of obedience means that you're ensuring that the organization is acting in accordance with that mission I described in the last slide and is complying with applicable laws. And not last, but certainly not least, is the duty of loyalty, which is that you must act in the best interests of the organization, not to advance your personal interests or the interests of another individual or organization who you may be affiliated with. So this is particularly important again when we're talking about the health center program because you are making decisions about procurements paid for with grant funds as an example. So your independence, your fulfilling that duty of loyalty is really important. So taken together, these duties collectively guide your oversight role. So you're not expected to manage day-to-day operations. That is the role of the leadership, but you are expected to ask questions, try understand implications, and prioritize your health center and its best interests. You can see here I have a link to a New York Attorney General resource that I found really helpful. And it is geared towards a New York nonprofit board audience, expanding upon these three fiduciary duties. Before I delve into here's the list of authorities you must exercise within the health center program, I think it's really helpful to take a step back and describe what are kind of some consistent themes in terms of your role. Because you will see this concept come up again and again. It came up when we were talking about fiduciary duties, but I think it will give you a clear insight in terms of why you're expected to make these authorities, what authorities you're expected to make, what kind of involvement is expected of you. So, in my eyes, I really like the analogy of the board functioning as like city planners developing a highway system. So, collectively, you as the board are making unified decisions about your strategic plans, new sites, large purchases. You are planners and you create the channels that management and staff must follow. So whether it's patient grievances, QI, QA, compliance. You aren't doing the implementation, but you are building the system. And you will periodically, through, as an example, QI, QA, audits, you'll evaluate the effectiveness. You'll identify where there's challenges, and you will ensure that there is some form of follow up. Um, and I think it's also helpful to think about how things break down when we aren't acting as a unit, when we are getting engaged in day to day activities, when we aren't exercising our authorities. Um, we'll get to that in a bit, but hopefully, this concept of we are building the systems, we are building the infrastructure, we are the city planners, we are looking ahead, we're making big decisions to adapt to challenges on the horizon. I think that is helpful when we start going through here are your specific authorities. Kind of following with that theme of you're building the highway system, you are the city planners, you're creating the systems, is this concept of the dance between the board and the CEO who is accountable to the board. I know I make this look like two distinct buckets, and I know that's not really the case. It's really kind of an active, fluid circle. But on one level, we have the board who is defining the mission, coming up with the strategic plan, defining the scope. Um, they are selecting the CEO. And then that CEO is actually performing the scope of project. Um, Selecting and staff, gathering data. So that is generally the distinction between the board and the CEO. And I have had whole trainings where we literally spend quite a bit of time on this singular slide. And you may wish to do that as well, because I think it's important to make sure that there is a clear understanding as to the distinction between the board and the CEO. So what are my top tips? What are my top tips in terms of making sure that we have an effective board? So number one, and this is what we're going to get to, do you understand and perform your responsibilities and not get involved in day-to-day activities? Are you engaged and prepared? Have you created those systems that are clear and being followed to monitor? And are we monitoring the effectiveness of those systems and ensuring follow-up? Are we continuously engaging in strategic planning? And are we cultivating a culture of compliance? So sometimes, now I want to kind of say what we want to avoid doing. And oftentimes we use the term rogue conduct, and there's a lot of like negative tone to it. Like you're really violating your fiduciary duties and you're um, doing something egregious. And I want to say, I have actually seen that this programmatic conduct, this rogue conduct we speak of, often evolves in a really seemingly innocuous way. And the person has the best of intentions. So it could be a complaint from a patient directly to a board member, and that patient asks the board member to help. And so that board member feels compelled and kind of starts their own investigation. Ding, ding, ding. They're not following the channel. There are channels in place that address how we're going to deal with situations like patient complaints. It is not at an individual board member level. That could also be an issue with a staff member who approaches a board member. In one instance, I worked with a board member who said to me, Carrie, I feel like Erin Brockovich. Do you know that Julia Roberts movie? And this board member said she feels the need to take it on herself, that there is this investigation that needs to occur related to this employment matter. No, no. There was employment counsel engaged, doing their work, doing an investigation. this person had the best of intentions, but it was just ruffling feathers and creating disruption. And when this happens, when we have this board member individually speaking on behalf of the full board, undermining the CEO's authority, not following those channels they've created, I almost can like hear the domino effect. First, it starts that there's maybe factions within the board. This group has their own text change. Then the CEO is kind of frustrated, like, my role is unclear. Somebody is kind of, these are certain authorities of mine are being infringed upon. It is making my ability to lead really darn difficult and in some ways unpleasant. Well, then that trickles to the staff, and then staff get frustrated, and then the patients. So you'll see I chose this image for a reason. It can start as a crack and it just gets bigger and bigger. And then we have this big pothole in our beautiful highway system. So having the highway system doesn't mean that we're always going to run smoothly or that we're never going to have a non-compliance issue. But that order, that structure is really, really important to our ability as a board to be effective. Currently, there's a lot happening at the federal level, at the state level. There's concerns about financial stability. And I find that board members often get approached to kind of weigh in on current events, how the health center is doing, etc. Just like any business, you all need to have a very planned, well thought out, discussed communications plan. So, a homework assignment for you would be to run through these three questions with your board and talk also about the fact that we aren't individually going to speak on behalf of the board, on behalf of the organization, unless authorized to do so. But what are some anticipated questions from the community about the health center? Sites had to be closed, there were layoffs, etc. How are we going to respond to those questions? Sometimes people will say, well, I'll just say, I can't respond or something that, well, you maybe don't want to go in depth, but maybe we have a response that speaks to our commitment to advancing the mission of the organization or something to that effect. But you want to be prepared because those questions are likely to occur. What about staff approaching us? Who are, if they have a concern, they have a question, what is our response to kind of make sure that we're following those channels? That's a great question, or I hear your concern. I really would recommend that you communicate to such and such. So plan ahead. Last but not least, similar with staff, patients. How are we going? What are the questions we're anticipating and how will we respond? I have done this with boards and it has been very, very effective. And then when those difficult questions arose, the board members felt equipped to speak confidently, not being worried that they were going to say anything that was problematic for the health center. So moving from that concept of this kind of communications plan, I think flows well into revisiting that concept of duty of loyalty and conflicts of interest. So, why is this particularly important for you all? Well, A, I'll talk about this in a second. New York nonprofit law has requirements related to conflicts of interest. And then also for you all, you are, as I mentioned before, stewards of this federal dollars and other community support. You're the face of the organization. You create that foundation of compliance across your organization. So your ability to ensure that there is transparency and your decisions reflect advancing the health center's interests and just the health center's interests and impartiality is absolutely critical, both in terms of compliance and kind of how your organization is perceived in the community. So I'll get in the next slide about, where they may arise, conflicts of interest. But you want to ask yourself a few questions. One is when we're thinking about a matter, and I say go beyond just procurements. When we're thinking about a matter, do you have a financial interest that may be impacted by virtue of that matter? How about a member of your family or household? I would add a close friend. And maybe you might say, no, or I don't think so, or something like that. You would then say, well, if there is that potential federal interest, excuse me, financial interest, does it compromise or bias your professional judgment and objectivity? Even if you conclude no, yeah, I have a financial interest, but it's my brother and it's so minor. So the answer is no. You need to go down to that third question. Could there be a perception that there is a conflict of interest? Because the concern related to conflicts of interest extend to even when we have a perhaps perception of a apparent conflict of interest. So this can arise in a number of contexts. So it could be an employment relationship, or seeking employment with an entity. It could be a business relationship, close personal relationship. This extends to kind of fiduciary duties. Maybe this is a matter where the other organization, you or your family member, has served on their board. And then just general active participant. So we really want to ensure that this concept of assessing conflicts of interest, we set a broad net. So in New York, you can see that there are specific requirements that you ensure that the directors, officers, and key persons act in the nonprofit's best interests and comply with applicable laws. And you must have a conflict of interest policy. This is also mandated by HRSA. There's actually a full chapter in the compliance manual on conflicts of interest. There is a distinct HRSA conflicts of interest policy. So that is in addition to these New York requirements that you are defining the circumstances that constitute a conflict. What are your procedures? Are we prohibiting conflicts of interest, or anyone with a conflict of interest from being present or participating in a deliberation, etc.? So, and are we documenting this and recording this, how we're managing this? So I have a couple kind of broad comments about conflicts of interest. One, it's not a bad thing. I often will say it's not a dirty word. Health center board members are often, and this is a great thing, very involved in their community in lots of respects. We have leaders from the community. So those individuals are inherently going to have conflicts of interest on occasion. So it is not that we have a conflict of interest, although sometimes they can't be managed. It is that they are disclosed and that they are managed. Those are the core requirements. I will also note that we have, yes, the annual self-disclosure of conflicts of interest, but please do think of this as an ongoing responsibility, not just something that is check the box, I filled out the form. So you always want to have on your radar this consideration of, do I have a conflict of interest? Could there be a perception that I have a conflict of interest? Because that is such an important role in terms of you promoting a culture of compliance and reflecting that you are good stewards of that those federal dollars, that designation, in compliance with New York law. So what are HRSA required authorities? So thus far, I've really been talking at kind of a high level. They're very specific, which again is a bit unusual in a grant program. So let's walk through them. So you have to meet monthly, at least monthly, with a quorum present. You define a quorum. The best practices webinar will talk about what that means. You have to record in meeting minutes your attendance, your key actions, your decisions. And you want to make sure that what is documented in those minutes reflect that you are exercising those HRSA required authorities. Your autonomy is really important. And this actually, HRSA will say, needs to actually be in your bylaws. So your organizational structure cannot allow for any other individual, entity, or committee to have approval authority or veto power over your board with regard to required authorities and functions. And if you have collaboration, relationships, agreements with other entities, they must not restrict or infringe upon the board's required authorities and functions. So, what are your very specific responsibilities? You can see here I have a bit of a checklist for you. You must, and only you, have authority to select, evaluate, and dismiss the project director. Typically, that project director is also the CEO. So no third party can define for you who will fill that project director role. You approve your health center project sites, its hours of operation, and the services. So this is that kind of scope of project we often talk about. So if the center wants to add a new site, wants to close a site, wants to change hours, add a specialty service, that all must be approved by you. Third, you are approving the applications related to the health center program project. So if you're a lookalike, that designation application. If you're a grantee, that service area competition or SAC grant application. Third, and this is where we often have a bit more conversation, is approving the annual budget and monitoring the financial status of the health center. You can see here it's not necessarily kind of selecting the auditor, although that may be something as well, but it is making sure you are reviewing the results of that annual audit and ensuring that there are appropriate follow-up actions as may be necessary. So let's talk about that budget for a moment for a moment. The board's role is not to build the budget, that's typically the CFO, but to understand what it's saying. Is it realistic? Is it reflecting stability? And we want to ask kind of about the assumptions that are kind of the foundation for that budget. So are the revenue projections reasonable based on what we know about patient volume and payer mix? What about our expenses and staffing expenses? Is that aligned with our operations? So, and then we also want the board, when we think about monitoring the financial status, is to be looking for risk. So are we relying on aggressive growth assumptions that might not be so realistic? And if we are, what if those assumptions don't materialize? So ultimately, when we're thinking about the budget, the financial status, a question is, does the budget position the organization to remain financially stable? And in terms of ongoing monitoring on a regular basis, which is typically monthly, the board should review financial reports to understand how the organization is performing compared to the budget. So are revenues and expenses tracking as expected? And if there are variances, why? I very strongly recommend that health center boards request training from the finance personnel to support such efforts. I myself have served on nonprofit boards and have raised my hand and said, this is not my area of expertise. I need some help understanding what my role is here. So please, please, please feel free to say, this is an area where we need some guidance from our CFO or perhaps a finance consultant. So now we want to focus on strategic planning, which is another element of the board authorities. So this focuses more on the future. So where are we going and how will we get there? So what are our capital needs? So buildings, renovations, equipment, technology investments, that needs to be part of that every 3-year strategic planning. Um, and then we are on an ongoing basis um, evaluating the performance of the health center based on QI/QA assessments. Um, and that, when you have a review, so this has to kind of be in your minutes as an example. They will look to see in the past, and I think it's 3 years, has the board reviewed those QI/QA assessments and other information and addressed follow-up related to, are we advancing and achieving those project objectives? What are our service utilization patterns, quality of care, efficiency and effectiveness, and patient satisfaction? So are we looking at all of these elements? And in terms of efficiency and effectiveness, I often get the question, kind of, what does that mean? Well, efficiency is really, are we using our resources wisely? And so that includes like staffing, whether we're operations are proceeding smoothly. And then effectiveness is the question of are our services actually working? Are we improving patient health? Are we meeting our quality goals? Are we advancing our mission? A common myth, and this can be a challenge for centers, is that the board has to approve all policies, procedures, protocols that relate to the health center project. In the weeds of collections, in the weeds of clinical policies that are really for an intended clinical audience. That is not true. So chapter 19 of the compliance manual sets forth that there are specific policies that the board must approve. So that includes certain personnel policies you see listed here: selection and dismissal, salary and benefit scales, employee grievance procedures, and equal opportunity practices. So let's go back to that highway system city planner image. So you're not identifying the compensation for each employee. You are establishing, other than the CEO, project director, you're establishing the salary and benefit scales, that system that the CEO in selecting staff then follows, right? Selection and dismissal procedures. You aren't deciding, with the exception of the CEO, project director, who is going to fill each role. That's really the role of the CEO. But you will establish selection and dismissal procedures that the CEO then follows. Again, one of those systems, one of those highway systems that you are creating, you are building. Same with the policies for financial management and accounting systems, in large part, to make sure that we are abiding by relevant requirements, particularly related to grants management, helping to build that QI/QA program. This is the big one, I think. All of these are important, but I am seeing more and more emphasis on the board's role in reviewing the sliding fee discount program. So determining our eligibility screening process. Do we have a nominal fee? If so, is it nominal from the patient perspective? This is an area where you want your minutes to reflect a lot of board discussion and involvement. It's very important. The last is billing and collections. So that's not, again, in the weeds of kind of the collections framework. It's focused on, is the board weighing in related to the specific circumstances when the center will waive or reduce fees based on an individual's inability to pay. This is entirely separate from the sliding fee discount program. So somebody over 200% of the federal poverty level may have their fees reduced or waived if they are, based on some health center board defined criteria reflecting an inability to pay. But you all need to define that. You all need to approve that policy. If your center is electing to limit or deny services due to an individual's refusal to pay, you must approve that policy as well. Now, for my public health centers in the audience, so there is a public agency with a co-applicant governing board. Do note that the public agency can retain authority related to the approval of those financial management systems and those personnel policies. There are some other decisions, not as common, but just to have on your radar, that the board must approve if we're going to subaward dollars, if we're going to contract for a majority of our healthcare providers, that's called substantive programmatic work, or we're going to relinquish our grant or transfer it. All right, so with the remaining time, I want to talk about, well, how are we assessed on this? What do we need to know? And how can we prepare? So once per project period, and HRSA is currently kind of shifting from 3 years to 4 years for most centers, a health center, each health center will have an on-site operational site visit, sometimes called an OSV. It's typically going to be halfway within your project period. So you can see here in 2025, there were 470 OSVs. There were over 2,500 findings. And I'll talk about what that means in a moment. So 2026, there are already many OSVs planned and occurring. So during this on-site OSV, there are 3 reviewers who are consultants to HRSA. So there's a clinical person, a fiscal person, and a governance administrative person. So these 3 people will come on site to do the tour and interview personnel. So the process is of the OSV aligns with this HRSA document called the Site Visit Protocol. And basically, it's instructions for the reviewers. There are very specific questions they need to ask, and there are yes and no answers. So HRSA has referred to the OSV and the Site Visit Protocol as an open book test. So this document will really give you insight in terms of what documents is HRSA going to request, how can the health center document compliance, and there are some comments in there that provide some clarification. I should also note that this site visit protocol aligns narrowly with the elements outlined in the compliance manual. So the timeline is reflected here. This is from a recent March HRSA webinar. But you can see here there's an initial contact from HRSA about half a year in advance that the OSV is coming. And there is a document request, there's a pre-OSV call, and then you have your on-site visit, generally like 3 days. I'm going to get in terms, I'm going to come back to this post-OSV phase in just a moment. So HRSA really recently said, and this isn't new, this actually has been the case for a number of years, I want to say, these are the most common non-compliant findings in the context of a site visit. So each of these headings aligns with a particular chapter of the compliance manual, a chapter of the site visit protocol. You will see too that board composition and board authority are 2 of the most common areas where there are findings. HRSA does not permit quick fixes during the site visit. They used to, but they do not anymore. So it is very important that you are prepared going into the OSV. This is a little in the weeds, and I know this is a lot of text, but I do think it's important that board members understand kind of the flow of findings. So the site visit will end. HRSA will issue a draft site visit report. You can provide some additional information to address the deficiencies and noncompliance identified in that site visit report. That is a 14-day window called the compliance resolution opportunity. So why do I think that's important for the board to understand? I think it's important for the board to understand in part because a number of the corrections to address these deficiencies may require board action, approving an amended policy, as an example. Um, I highly recommend that the board remains very engaged during this period because you may very well have to have a meeting to address that. So I recommend the board is kind of prepared with a meeting pre-scheduled to address potential findings. So after that 14-day window, the window closes and HRSA will prepare a final site visit report within 45 days, and it will convey the findings, compliance decisions, and anything that remains non-compliant and was not resolved during the CROW, which is the acronym for Compliance Resolution Opportunity. You're going to see a condition on your grant, on your lookalike designation, for each of those non-compliance findings. And if you want more information about that process, look at the compliance manual. You start off generally with 90 days to resolve, then 60, then 30. But we want to try to avoid as many findings in the first instance as possible. So for board members, you're probably wondering, well, how do we prepare? So first, you want to ask your management, your CEO, kind of how are we preparing? What is your game plan? So your job is not to go through the site visit protocol and read everything and make sure you have all the documents, but you want to put some pressure on your management team, your CEO, to make sure that they are taking the steps to prepare because it is a lot of work and really does require, I always say, divide and conquer several people from the health center to really actively being involved in making sure we have the documents, going through that site visit protocol and its questions. And one person just simply can't do it all. So, in addition to that, HRSA has issued a list of kind of it's guidance for the consultants, but you have access to it. Here are the types of issues we want you to address in the interview with the certain personnel. So what I have done on this slide and the next slide is here are the questions related to the on-site interviews and interactions as between the reviewers and board members. So you can use this and it will give you a heads up for the types of questions the reviewers will ask because a component of the operational site visit is an interview, a meeting with the board. So you want to be prepared for that. And I like to say this is your opportunity to shine. You all are amazing. You are volunteers. You donate your time to support this wonderful organization in your community. You are committed. So let's show off. So, and that can be a more enjoyable experience with this operational site visit with these reviewers if we take the time to think about the kinds of things we want to highlight, the questions we think they're going to raise. And so I have on these slides, in addition to kind of HRSA saying, here's what we're going to talk about, I have laid out some questions that I recommend the board sit down and discuss because if there is a question about, can you give me an example of an amendment you made to a policy over the last year? If you haven't stopped to kind of think about that, you may be like, well, I don't know that we have, or wasn't there that it's going to be a more interesting conversation and you will be more likely to reflect compliance if you have thought about these questions in advance. So take these questions and add to them and have some internal discussion. And you will do a great job within your OSV. So with that, I will just wrap it up with just some broad strategies to enhance the board effectiveness in exercising these authorities. Some of this is going to be covered in the next webinar. on or the separate webinar on best practices, but do we have a board calendar to monitor all these authorities? Um, are we training new staff, new board members? Um, are we giving board members a refresher on their responsibilities? Are we making sure, given all the things the board is being asked to do, that we're giving the necessary information? Not too little, but also not too much. And with that, I mentioned this before. Do we need some training to help give some context to the authorities that they're having to exercise? Are we using our committees efficiently and effectively? For example, I just looked at a set of bylaws, and a lot of the efforts related to recruitment and monitoring the bylaws and doing a lot of the more in-depth financial monitoring was all done through committees. That's very, very common. And then are we asking the board or permitting the board to get involved in matters that are in the weeds of the day-to-day operations? Because again, that is why the CEO is there, and you all have a very full plate. And that can, as I mentioned before, create challenges in terms of operations. So with that, thank you for joining. I hope you listen to the other two governance webinars, and please do reach out to Chicanis with questions. They can always come back to me and find me. Thank you.
Thank you so much, Carrie, and thank you again to all the viewers and anyone who is also serving as a board member at your health center. We appreciate your service. We hope you will view the rest of the Chicanis Health Center Board training series included in the playlist. And as a reminder, you can access a copy of the slides and also a brief feedback survey in the video description, which we really encourage you to complete. Thank you again all for viewing this recording.